Good morning, everyone. Today we are going to investigate a real clinical case together. I want you to think like clinician and laboratory professionals. Don't worry if you don't know all the answers yet. Our goal is to use the patient history, physical finding, ECG, and laboratory result to determine whether this patient is experiencing a myocardial infarction. A 53-year-old woman presented to the emergency department. She complained of squeezing chest pain located behind the sternum. The pain radiated to both arms. She also reported palpitation, excessive sweating, dizziness, and shortness of breath. The symptoms began approximately 4 hours ago. She has no history of smoking. She denies illicit drug use. She has no known history of hypertension, diabetes mellitus, hypercholesteremia, or previous cardiac disease. Her ECG demonstrates mild ST segment depression measured between 0.5 and 1 millimeter. Her are also follows: blood pressure 163 over 102 millimeter of mercury, heart rate 58 beats per minute, respiratory rate 18 breaths per minute, temperature 37 degrees Celsius. Before we look at any laboratory data, I would like you to think about the following question. Based on the history and EKG findings, what is your leading diagnosis? Pause for a moment and think. Many of you are probably considering acute coronary symptoms. Excellent. Now let's examine the laboratory findings. The following laboratory results are obtained over a 30-hour period. At 6 hours, total CK was 176 units per liter. CKMB was 8 nanogram per milliliter. Troponin T and 100 was 100 nanogram per liter. At 12 hours, total CK was 195 unit per liter. CKMB was 140 nanogram per milliliter. Troponin T was 5 nanogram per liter. At 18 hours, total CK was 175 units per liter. CKMB was 10 nanogram per milliliter. Troponin T was 800 nanogram per liter. At 24 hours, total CK was 98 units per liter. CKMB was 6 nanogram per milliliter. Troponin T was 703 nanogram per liter. At 30 hours, total CK was 84 units per liter. CKMB was 4 nanogram per milliliter. Troponin T was 350 nanogram per liter. Take a few seconds to examine these numbers. What immediately stands out? The answer is troponin T. Even at the earliest measurement, troponin T is markedly elevated. More importantly, it demonstrates a clear rise followed by a fall. This pattern is extremely important. Let's discuss why. Understanding troponin. Troponin is the most important cardiac biomarker used in modern medicine. Troponin is a protein complex involved in muscle contraction. It consists of 3 subunits. Troponin T bind to tropomyosin. Troponin I inhibit actin-myosin interaction. Troponin C binds calcium. When cardiac muscle cells become injured or die, troponin leaks into the bloodstream. Because cardiac troponin are highly specific to heart muscle, their presence in blood is strongly evidence of myocardial injury. The key concept is not simply an elevated troponin. The key concept is a rise and a fall pattern. A changing troponin indicates an active injury process. A stable elevation may indicate chronic disease rather than an acute infection. Now let's return to our patient. Troponin T increased from 100 to 500 and then to 800 nanogram per liter. After reaching a peak, it began to decrease. This is a classic pattern of acute myocardial infarction. CKMB analysis. Let's now evaluate CKMB. Historically, CKMB was not one of the primary biomarkers used for diagnosing myocardial infarction. Although troponin have largely replaced CKMB, understanding this marker remain important. Notice that the CKMB concentration rising from 8 to 14 nanogram per milliliter. The value exceeds the commonly used threshold of 10 nanogram per milliliter. This finding supports myocardial injury. However, CKMB alone is not sufficient. This finding supports myocardial injury. However, CKMB alone is not sufficient. We must calculate the CK index. Calculating the CK index, the formula is CK index equal CKMB divided by total CK multiplied by 100. For the 12-hour sample, CKMB equal 14. Total CK equal 195. Dividing 14 by 195 give approximately 0.072 multiplied by 100 gives CK index of 7.2. A CK index greater than 2.5 strongly suggests cardiac source. Let's calculate the remaining value. At 6 hours, the CK index is 4.5. At 12 hours, the CK index is 7.2. At 18 hours, the CK index is 5.7. At 24 hours, the CK index is 6. At 30 hours, the CK index is 44.8. Notice that every value is greater than 2.5. This strongly supports myocardial damage rather than skeletal muscle injury. Clinical reasoning. Now let's put everything together. The patient has typically ischemic chest pain. The ECG shows ischemic changes. Troponin T is elevated and demonstrates a significant rise in the fall pattern. CKMB become elevated. The CK index remain consistently above 2.5. What diagnosis best explain all these findings? The answer is acute myocardial infarction. According to the universal definition, the myocardial infarction, the patient fulfills the diagnostic criteria. There is evidence of myocardial injury demonstrated by rise and fall in cardiac troponin. There are symptoms consistent with myocardial ischemia. There are supporting ECG abnormalities. Taken together, these findings confirm myocardial infarction. Let me share an important clinical pearl. Notice that the initial total CK value was 176 units per liter. The laboratory reference interval is less than 175 units per liter. Some students may wonder why the total CK is almost normal despite clear evidence of myocardial infarction. The explanation is that total CK is much less sensitive than troponin. In addition, CKMB represents only a fraction of the total CK present in cardiac tissue. A patient may have significant myocardial infarction with the total CK remain near the upper limit of normal. This is one reason why troponin have become the gold standard biomarker. Let's test our understanding. What is the most important biomarker for diagnosing myocardial infarction today? The answer is cardiac troponin. Question 2. What pattern in troponin value suggests acute myocardial injury? The answer is a rise and fall pattern. Question 3. What CK index value suggests cardiac source? Pause. Try to answer yourself. The answer is greater than 2.5. Question 4. Can a normal or near normal total CK exclude myocardial infarction? Your turn. The answer is no. Troponin is far more sensitive. Before we finish, remember these 5 points. Number 1, cardiac troponin are the gold standard biomarker for myocardial infarction. Number 2, always evaluate serial measurement rather than relying on a single result. Number 3, a rise and fall pattern is essential for diagnosing acute myocardial injury. Number 4, the CK index helps distinguish cardiac injury from the skeletal muscle injury. Number 5, laboratory results must always be interpreted together with clinical finding and ECG. Thank you for your attention.